Yeah, thanks, Brian, and welcome everyone for joining us today about smart rooms and smart patient flow and how to design the virtual care behind that. I'll start out by having our panelists introduce themselves because we've intentionally gathered people who are looking at virtual care from smart rooms from different perspectives. I noticed the registration list, we're up to almost, or maybe even over 300 attendees. You all are also very diverse, coming to us from different perspectives and different roles. So today we have three physician leaders joining us, a very seasoned operational leader, and I myself bring a nursing perspective after 20 years of bedside care and leadership, and then moving into the tech industry about 12 years ago. So I'll let everyone introduce themselves, and let me start with you, Leslie.
Hi, good morning, good afternoon, everyone. I'm Leslie Farrell. I'm the Administrative Director of Virtual Care and Patient Engagement at Harris Health. We are the safety net system serving Harris County and the greater Houston area. And I am happy to be with you all this morning.
Thanks, Leslie. How about you, Dr. Lar?
Hello, everyone. Stephanie Lar. I'm an internal medicine physician by background, practiced as a hospitalist for many years, then got involved in informatics and IT, spent a chunk of my career in CMIO and CIO roles, then transitioned to the vendor side a few years ago. So I've really grown to appreciate the industry from multiple perspectives. I now run my own firm called Vital Thread Advisory with specific interest and emphasis in the smart hospital and virtual care continuum.
Thank you. Dr. Bacher?
All right, good afternoon, everyone. Mo Bacher. I am the Vice President for Hospital Medicine for the East Region with Envision Physician Services. Part of what I do is I provide clinical services at Jersey Shore University Medical Center, which is a part of the Hackensack Meridian Health in New Jersey. Happy to be here.
Thank you. And you got an emoji. And Dr. Fusaro.
Hey everybody, Mario Fusaro. I'm the Chief Medical Officer of Equim Medical, pulmonary critical care doctor by background. Been in the telemedicine space for about 10 years now. Looking forward to talking with everybody today.
Yeah, thank you all. So for years, health systems have been buying virtual care technology one problem at a time. So there's like one solution for virtual sitting, another one for virtual nursing, and then telestroke's got its own thing. Stephanie was talking about a robot that she used to have a drive around that had her face on it, and then she had to like back it in to get recharged, adding like quite a bit of stress to your virtual visits. But it's a really changing dynamic time now, because at the same time that we are experiencing really rapid advancement in AI and digital health technologies, we're also experiencing strong pressures from hospitals to consolidate into fewer, more connected platforms. And so I'm wondering give like a thumbs up or something if you have for many years been talking about the smart room of the future. How many years have you been talking about the smart room of the future? Yes. So yeah, I think it's no longer the room of the future. The smart room isn't just a new concept, and the technology that truly makes a room smart is now becoming possible. However, I don't think there's really a single industry definition yet. So that's where we're going to start, from all of us looking at this elephant from our different angle. Let's us start by, how do we define a smart room? And Stephanie, I'm going to pick on you first because you, I think, have been spending a lot of your focus in the last few years on this.
Yeah, the evolution really is very exciting. I think, a smart room to me is where technology is intentionally integrated to extend the capabilities of the care team. So from a, foundational perspective, that includes things like cameras, speakers, microphones, digital whiteboards, communication tools, ambient sensors, potentially AI algorithms layered in to support and analyze video and audio feeds, EHR integration, clinical decision support tools, and virtual care platforms, but all with this sort of intention of coming together to create a cohesiveness and an ease of flow so that clinicians can take care of patients in the best way possible, removing friction from the care delivery to the point that really the technology, and this is where the word ambient sort of comes into play, the technology fades into the background. And the emphasis is really on connecting the right people, the right information, and workflows at the right time. I also think that it's important to add that as we think about the smart room, we're really evolving to what should be the smart and will be the smart hospital, which is then the networking of bringing together the individual elements that support that care in a room and on a more broad perspective, allow us to take things to the next level and have the data, the analytics, and the information necessary to support things like throughput and efficiency and quality delivery improvements, et cetera.
Yeah, that's the dream. So Mo, when we were doing our prep session last Friday, he was like, just a second, I got to put in this neuro consult. I'll be right back, So you are really out there front line seeing patients every day as a hospitalist. From your perspective, when somebody says smart room, what are you thinking about?
Well, I'm sure Stephanie would relate given her experience in hospital medicine. We are always on the go, and I'm sure Mario as well with the ICU world. I believe that really multitasking is the name of the game now in what we do in our day-to-day operations, and what Smart Room really offers or kind of allows is increasing that horizon of what we are capable of offering our patients and even beyond. Meaning, we are obviously giving that bedside care. We are going to the patients and their family. It is not uncommon that I get paged because a patient's family showed up after I've spoken to who I feel was already the family, but they just wanted an update. And by no means, obviously, am I or preaching to any of my colleagues that we basically already spoke to someone or we're not going to answer the questions or so forth. What a smart room could offer, and what basically the capability that this can actually give me is allow me to put in that consult in my own space in whatever I'm doing, but also get onto that line and into that capability of being able to give the patients and their family that increased awareness and answer the questions that they might have. And as a matter of fact, at Jersey Shore University Medical Center, we have had the pleasure and experience of working with the Avasure product to be able to be in the patient's rooms at their demand when they are having questions or they need follow-ups and so forth. And on that domain, I actually also believe that it not also only helps with patient experience and improving the value that we are providing, it also prevents very important things like readmissions and so forth, because it's not uncommon that I might have forgotten to tell the patient or their family something that could be detrimental in their care, and with this capability can get onto the call with the family and the patient and tell them, oh, don't you forget, this is the diet we're going to be following to prevent us from coming back, or that medicine was supposed to be twice a day, not once a day, and so forth, on top of everything else I said.
Yeah, it's exciting to just have a smart environment that just enhances care, and hopefully you're not even thinking about it. Leslie, how about you? You've been in telehealth, telemedicine many years in a couple different big health systems. So what's your perspective on that smart room, or how do you define it?
Sure. I think both of our providers on the line have absolutely given perspective on that. For me, I think certainly the technology in the room matters. It's the capability that that technology creates without being an imposition to our patients. So when we're designing these rooms, particularly for inpatient, what can that room now allow us to do differently from a patient care perspective, how can we improve the workflow and be removing some of the burdens perhaps that we've placed on our inpatient and in-person workflow. So that environment might transition a little, right? So it's connecting specialty expertise so that the provider's not running down the hall for that consult that they're trying to make before somebody has to go back to work, or supporting the in-person staff with patient education. So I think about all of the things that we can bring into that room for the patient care that expand our capabilities.
And yeah, that's you're talking my love language there. Like the bedside, like it's always kind of the nurses like, well, we need this other thing done, so ask the bedside nurse to do that, and this, and then this, and then this, and then this. Um, Mario, you've been in like virtual ICU and for many years. So how have you seen the sort of smart room evolve?
Yeah, I mean, I think I agree that it's not really the smart room anymore. It's really the smart hospital. You
Yeah.
know, these technologies are required to sort of reduce the friction for all the operators involved, whether it be nursing care, physician care, respiratory therapy, whomever. And the whole idea is to improve smart flow. And to me, smart flow is really relieving bottlenecks throughout the entirety of the hospital, whether that be in the ICU, the floors, the emergency department. What we're trying to do is create seamless patient flow throughout the entire system. And so that might start in the ICU where there might be, overload of patients in the ICU. There needs to be another provider there to help take care of those patients. It could be on the floor, it could be, that overdose patient in the ICU that needs to be cleared by telepsych. Otherwise, they'd be sitting in the hospital waiting days and days to go. Or it could be that telehospitalist that's working in the emergency department during surge conditions so that those patients aren't backing up waiting for admission. There are opportunities, I think, throughout, and really, these technologies allow specialty care, specialty nursing, all of those, people to get into places where they may not normally be able to because of geographic constraints or really just, scarcity of coverage. But to me, that's really what you're trying to do with smart flows. You're trying to reduce relief bottlenecks throughout the system, wherever they may be.
Yeah, thank you for bringing us back to the title. Talking about smart rooms to smart flow. Maybe should have been smart hospitals designed for smart flow. But then I think what I also heard was kind of like an ROX, the return on the experience, whether that's for the hospitalist who is able to not have to run down the hall, or nurses, that the workflows can be a little unburdening with that. So let's talk about the starting use cases. Like, where do you get started? And so Mo, you started talking about some of the use cases that you're doing there at Hackensack. Um, can you share some of the problems that you were solving initially over the last couple of years with
Well, I think one of
platform?
Yeah, I mean, one of the biggest, I'd rather even say challenge than problem, is that challenging the status quo is always a challenge. We all kind of get comfortable, and we don't necessarily really know how to get comfortable being uncomfortable. So we're all doing something one way, and to basically just go out there and basically say that we're changing the way we're doing things and or implementing technology is not necessarily always as well accepted, both by the providers, the clinicians, and then obviously also the recipients, which is the patients and their families. I would say that it's a good problem to have, and a good growing pain, if you may, because the more we start accepting it and the more we start realizing what the ROI and what our return on the investment is, the more we realize that we're actually able to touch more humans and touch more lives with that capability. Now, obviously, one is to always be worried that what if the technology fails, or let's say the connection is not the best, and I cannot speak. We haven't encountered any of that, honestly, during our experience to date. With this, we've actually kind of followed the track with what nurses have been doing here. We do have a discharging nurse, there is a tele nurse that goes over the discharge paperwork, and that's actually available in multiple healthcare systems. And I see how beautifully this is done and how enlightening it is for the patients and the families. So I would say one of the biggest challenges really is the engagement, and getting the clinicians to believe in the product, and then for that being able
Yeah.
to actually take it further and have the patients and the families believe in it as well.
Yeah. Yeah. I love what you're doing there with the kind of the afternoon boost rounds that the hospitalists are doing more virtually. So they're and with a real focus on patient experience. Leslie, how about you? What are some of the starting use cases that you've started with at Harris?
So one of our easiest starting use cases, I'm going to say easy in my air quotes here, but one of the things that we were trying to solve was around patient safety. And so this is in no way a commercial, but we did happen to partner with Avasure for this initiative for virtual ops, virtual sitting, because we had resource constraints. So we wanted to make sure that we were keeping patient safety as a top priority, using the limited clinical workforce that we had. How can we do that as effectively as we possibly can? So we started creating kind of a different model for us anyway, several years ago. And so that's who are these patients that we need to keep extra eyes on. We're not replacing any of our bedside personnel. We're just taking some of that burden off of expecting them to be all knowing, all seeing at every point in their day for these subset of patients that they're managing. How can we share that responsibility? So we went through kind of a checklist. It's like, okay, who are we going to monitor? What are we monitoring? What's the tech that's going to support us in that effort? So I think our nurses have really enjoyed having that piece kind of, they've got that assist, right? They've got that extra set of eyes supporting them. And if that observer is recognizing something that the patient's beginning to get out of bed, there's an early intervention. And so we can start to move those pieces more quickly than with that responsibility have been solely on the bedside nurse.
Yeah, I love that it's the patient safety, preventing falls and those types of adverse events. But I love how you mentioned the nurses, because as a bedside nurse myself, if I had multiple patients that I was responsible for, and I just knew in the back of my head that one patient, was at risk of, pulling off their BiPAP or, falling, it was hard for me to be fully present with the patient I was with, because I was kind of like had one ear out. So I love how you mentioned that also helps them, the nurses at the bedside. Stephanie, you are consulting on this. You're seeing multiple different health systems. You've worked with a health system in a rural setting. So when somebody comes at you, like, where do I start? How do you help guide through kind of initial use cases for this type of technology?
Yeah, I mean, the age-old approach of what's the problem you need to solve is the best initial question. I know it sounds obvious, but it's a combination of evaluating what are, to Mario's point, what are the bottlenecks? Where are the challenges? Where are the spaces where you have inadequate coverage or service, where you might need to extend it? What are the places where patients are getting stuck? And then what can you do? And sometimes those are clinical things like trying to solve a falls problem, but sometimes those are throughput challenges, trying to improve a discharge workflow or to keep patients in a specific region or closer to home. And so exploring ways to be able to extend care into that environment that allows them to safely stay in those environments. So really the first question is, where there's lots and lots of opportunities. So one, let's start with a problem you really have, not just, what you may have heard on this webinar or somewhere else. And then what are the friction points around deploying? Virtual nursing programs have gained a lot of traction, but for them to be truly transformational is a massive overall undertaking. It requires infrastructure to be put into dozens, if not hundreds, of rooms to really maximize the investment in both the nursing, et cetera, and the technology. And that takes a big lift on, from a cultural perspective, from a change management perspective, and even from a technology perspective. So, what are the places you have a problem you need to solve? And also, are there ways to chip away at that in a way that doesn't require such an initial huge lift? So, are there problems you can solve where mobile devices or cart kind of infrastructure can get you started and help support the transition in the cultural change, can help improve the workflow and the buy-in while you then expand into areas where you're going to put in more infrastructure, et cetera. So it's kind of finding the cross section of the problem you need to solve and the tools you have available with the juxtaposed against what does the lift of that look like, and try and find the combination of lower lift, high impact
Yes.
problem so
Yeah.
that you can really demonstrate success and then build your program from there.
Yeah, I was talking to a system chief nurse last week, and she said it so well. She said, I think the smart hospital investment is the most important thing we need to do for our future, but we have to survive today. And so I think that's kind of how you ease into it, like picking out the use cases that really have an impact so you can get onto that most important thing that you can do for the future. Um, let's shift into like really like getting tangible. What metrics are we measuring? What's the ROI, and how, and that's what's needed sometimes to convince people to make that investment. Mario, you were starting to talk about that when you were even defining what a smart room is. You were talking about flow. Can you give some examples of actual metrics, actual outcomes, maybe financial, that really will help maybe the audience when they're making a case. Oh, you're on mute.
Yeah, absolutely. I think, when you're thinking about outcomes, I think Stephanie said it, nailed it. Basically, you're looking for the biggest pain points and you're looking for sort of the easiest things to fix within those pain points. When you're talking about specific use cases and outcomes related, I think there's kind of two of them, right? There's experience related, that
Mm,
patient that would have ordinarily not been able to see a doctor at 2 in the morning, they can, hear the story, or that patient in the ICU that's maybe, family wants to have that goals of care discussion and they don't really want to wait the 5 hours until the bedside comes back.
mhm,
Also that patient that may be in a hospital setting where the nearest hospital is 4 hours away. There's 2 points of that. There's both an experience return, but also ROI for the hospital. If you can utilize these technologies and these providers to keep people in situ, meaning that you have that patient who's having some shortness of breath, maybe they're having some elevated cardiac markers. There's not a cardiologist in this system. You bring in a telecardiologist, they can look at that and say, you know what, this patient probably can be safely treated here. That's a tremendous experience for the patient that they don't have to travel that 4 hours. And also the hospital keeps that patient within the system.
mhm,
So those are two examples, along with the examples, the outcomes the examples sort of lead to the outcome. So, for example, if you want to keep as many patients within the ICU as possible, if there are a lot of boarders in the ER, for example, there might be patients you can safely treat in the ER and then have them downgraded so you open up flow downstream for the ICU. And so how do you measure these things? So for clinicians, one of the most important things we're always looking for are clinical outcomes, right? We want either clinical improvement or sustained excellence. In my line of work, we look at mortality, we look at length of stay quite a lot. Obviously, patient satisfaction are important, staff satisfaction is important. Um, you know, Things like how many new patients did you bring through the ICU? Tangible measures of patient flow, um, changes in length of stay, so reductions in length of stay. um, increase in the amount of downgrades from higher level care you get before they hit the ICU. These are all tangible outcomes that one can look at based on the examples that I just gave you.
I love how the experience, that example is just the experience and then the finances are very intertwined. So someone gets to stay close in the hospital that's closer to their family, closer to their home, but then the health system, so that's great on experience, but then the health system retains a patient that doesn't leak to another health system, or the cost of transferring to, the tertiary, quaternary health system. So yeah, they're often very closely related. Leslie, we had some good conversations about this when we were talking last week. What are some of your measurable metrics that you're looking at?
Sure. And I loved Mario's answer because I think sometimes we get so focused on what is that financial return
Yeah.
that we forget to pay attention to workforce capacity, patient safety, throughput, access to expertise, staff experience, patient experience. All of those things matter. So measures that we utilize are observation hours that we provide virtually. Was there a reduction in reliance on one-to-one physical observation? Did we prevent any falls or safety events? We have near miss and close call huddles so that folks feel psychologically safe to say, whoa, we had a near miss or a close call. This is how we handled that situation, and they share that best practice. Obviously, response time and escalation time are important. Nursing time. I'm daughter of a nurse here, so I think she instilled in me nursing time is very valuable, and how can we return some of that to the bedside care and take off some of that administrative, like we talked about. And then discharge timing. Can we free up the bed a little bit faster? Can we downgrade that care? Can we move them to a step down unit? Can we transition to hospital at home? What are those things that we've got the potential for? I think another thing is we put this in place, but is it being utilized? Is it widely adopted? And then what does that experience measure? Are we getting that return? Is it doing what we thought it was going to do when we put it into practice?
Yeah, kind of that. Some of those leading metrics and then the lagging ones as well. How about you, Mo? Do you have anything else to add that we haven't talked about?
I mean, it's really been said great, both by Leslie and Mario. And I would just say I like to approach metrics in general that it's simple. We all here are thinking in the mentality that we're doing what's right for the patients because it's simply the right thing to do. Metrics usually follow, really. And, I believe that we know we are in a value-based care. Heads to beds is important. Obviously, it's important to keep a hospital busy and obviously filled with patients. It's a healthy reflection, but also the value you provide is more important than ever now with what value-based care is all about. And all what this is about and increasing the capability to give more value. And Mario said a great point. It's satisfaction for the patients and for the staff. I think, a happy staff in any line of industry gives a good service. If you can save me an unnecessary drive as let's say a consultant or a hospitalist or whoever we're doing to prevent myself from going all the way to see a patient that I could have answered the question towards by a televisit, obviously that increases satisfaction. It lowers your traffic time. It allows you to be able to actually get more work done in a more decent amount of time and such. So I do believe that what this really offers is not only patient-centered, which is obviously the bread and butter of what we do on a daily basis, but it also allows for the physicians and the clinicians in general to be able to provide the care without having to cut a lot of time that could be saved and then leads to satisfaction and that keepage mentality. It's not uncommon we get patients transferred out to the second or the minute the patient gets evaluated, gets told no service could be provided or we're not going to offer more service by a neurosurgeon or a consultant, but then the patient stays because they already got transferred and you lost them from your network and from your system when maybe this question could have been answered and to the advantage of the patient, and then also tying that with what is right to be done also will align with the goals and the metrics, would have prevented that patient from getting out of the system. And you've gotten that answer to your question while the patient is in their bed at their own leisure, and not and could avoid that unnecessary transfer and getting out of the system.
Yeah.
Elizabeth, there's a couple things that come to my mind when I hear all of this because, I've sat in rooms even at the ATA and heard people say, we're seeing great things, but it's not translating at the senior executive level into continued investment. And I think some of the challenge there is the things that everybody just talked about are absolutely the right things to measure. They're the downstream impacts versus the actual measurement of activity. How many consults you did and those kinds of things isn't really where the value is. But in so many cases, these programs are designed based on, a service line that's being asked to pay for something, a unit that's being asked to pay for something, when really the benefit sits at a much broader level. So that example of the patient who is able to stay at a local organization, how do you measure and track the idea that by that person not going, even if it was within the same health system, if the cardiology service now isn't taking care of that patient in the tertiary care hospital, and now an additional cardiac cath is able to be done on a patient who might have waited or chosen to go somewhere else because of a wait time, those things are 1 to 2 steps removed, if not three at times. I worked with an organization once where they really needed to improve OR utilization. They actually had time in the OR to do the work. The problem was they didn't have the place for those patients to go to recover afterwards. Those that needed, for example, med surg admission and couldn't just, be sent home. So the problem they needed to solve was a med surg capacity issue. Improving the flow on med surg allowed them to add surgical cases in the OR. The way we track all of that is very distinct and separate. And we have to, as organizations, health system organizations, challenge each other to say we are not going to look at things in these siloed financial buckets, because the impact of this transformation in care sits at a much higher level. And so it is going to be hard work and a bit tedious to figure out how to get those measurements. They're probably not things that you necessarily are measuring out of the gate. And so figuring out what are those things, what do you need to put in place to at least do some temporary or spot measurements so that then downstream you can recognize the improvements that you believe are going to happen.
Yep. Here, here. I forgot to do my emoji. I would clap to that one. So in the time that we have left, I want to talk about both, some lessons learned, some like practical lessons learned, but also future vision. So we're talking about some of the emerging technology and ecosystem in a smart hospital, and how that's going to impact. So let's start with some lessons learned, a deployment that's stalled out, or something you would have done differently in hindsight. And I'll put you on the spot first, Leslie, if you don't mind.
Oh, sure. I I feel like I've got multiple handfuls of these examples,
Sure.
but the deployments I've seen struggle generally haven't struggled because the technology didn't function. They struggled because we underestimated the operating model that we needed to have around it. We needed to have a better communication plan. We needed to spend extra time on the change management to make sure everybody understood why we're doing it, because we're not trying to give them a process for the sake of giving them another process. We're trying to improve on something. So before we deploy it, we need to understand the work we're asking people to change. And I think once we started involving our frontline users in a lot of that change management, having those change champions and saying, I think I'm trying to fix this right. Can you provide me some context? How is this going to work in real life? Because what we make in Visio and every fishbone diagram and root cause analysis, that's one thing on paper, but what does it actually translate to in their work capacity? Are they going to adopt this workflow and this technology like we've designed it, or are they going to find a workaround because they're very, very crafty at finding those workarounds? Because we put something in their way. So how do we find out early on what's the thing we put in your way that you are ultimately going to find a workaround and not use this as designed?
Yeah, I'm thinking of just an example of that is the ambient documentation for nursing. You can't just plug and play the ambient documentation for physicians onto a nursing workflow because nurses don't necessarily care out loud the way, and they don't have as much narrative notes. And so that type of implementation would need a lot of that kind of work that you're talking about. How about you, Mo?
Well, I mean, I will make it a little bit less sophisticated and say that one of the rooms that we were basically utilizing the technology, it's a double, bedded room, shared room, and we had the encounter, which the patient and the family were very happy in the B bed. And the success story in that room was that the A bed patient and family went to the charge nurse and asked to also have the same capability to be able to connect with their doctor, which I found to be really interesting because we all know in the marketing approach, word of mouth is one of the most common and oldest way of branding a product. I mean, we all use technology now and advertisements and so forth, but really the word of mouth and is still the core and is a reflection of what someone has really felt, and to just kind of see what a patient and a family overheard from their neighboring bed was really a great success. But in general, overall, I really think that major opportunities do fall into this category. I mean, great points have been discussed. It's really enlightening to myself as I listen to this from all the amazing panelists, and it really is just what the future. And I believe that while COVID had its scary many things to many of us, especially I'm sure Dr. Fusaro, in the ICU world. But I will say that one thing it has really opened our eyes to was that telemedicine is possible. I mean, all those visits that prior to COVID would not happen outside of the office setting or the hospital setting had really started happening more often in the tele medicine world, and patients lived, and more generations are being made and so forth. So clearly it's working. And then all the advantages we mentioned on that just kind of augments how important and valuable this product is.
I love, I love that you, the patient in the other bed had FOMO. They're like,
Yeah, they got
well, I want
jealous.
to talk to Dr. Bacher. How come I
They got,
can't talk to?
they got jealous. They're like, what's up with that? He's up in the wall and stuff. Like he's gonna jump on the bed. Like what's going on here?
Oh, that's awesome. Um, Stephanie, what are some, look, from your perspective, seeing many health systems, what are some common lessons learned that you can share?
Yeah, I think they were sort of inherent in both of the comments that Leslie and Mo made. First, when it gets viewed as a project, rather than really a transformational opportunity to change care delivery, then you end up either with one leader carrying the weight of this whole thing on their shoulders, and it's not sustainable. It's not, it takes getting all the way to the bedside, getting the buy-in, finding the right group of people initially to say, yeah, we're willing to change the way we do things. Mo said this earlier, right? He was like, we are not always the most adept at wanting to change, even when we know there's something better. I had somebody give an example once about when you move into a new house, like you buy a new house and are moving to a new house because you really want to, but the process is pretty terrible. And we have to go through those angsty periods. And that means It can't be on the weight of one person's shoulders. It can't sit in an innovation bucket. It
Oh,
really has to be this concept of care transformation. And then the other thing on the back end is a failure ahead of time to really define what success is going to look like. It's really easy to find fault and or lack of success in programs when you want to, and there will be some people who are not as excited about moving these things forward or need more convincing. And so I've seen programs maybe not fail, but stall significantly because everybody agreeing ahead of time that if this and this and this happen, we're calling that success, and it may or may not be financial, then we are going to continue and we're going to expand those. If that discussion isn't had early and documented, then you've got pushback later and people wanting to drag their feet on really moving things forward.
mhm. Um, no, I want to make sure we have a little bit of time to get like visionary and talk about what's coming down next and a vision for the future. We had a really good comment in the Q&A by Eduardo Alfonso talking about leveraging AI healthcare agents before, during, after patient encounters to expand capacity and optimize care. I heard a nurse who was skeptical, a nurse leader is very skeptical about agents talking to patients, share a story where an agent was calling a patient and the agent's goal was to get the patient to reschedule their appointment because they missed it. And it turns out that the patient's son had died. So he missed doctor's appointment because of that. And so the nurse heard heard the recording of that call, and she was thinking, "Oh, this is going to be terrible." But the AI agent said, "What was your son's name? What was your son like? What is there anything we can do?" Because the agent had all the time in the world. And so I am optimistic. I certainly don't want to replace RNs, nurses, scope of practice, or physician scope of practice, but I think futuristically there's just so many potentials for where we're going and going quickly. Um, Mario, you where do you like where are you excited about seeing this in the next couple of years?
I mean, I think agents are going to, at some point, agents are going to end up being integrated in all aspects of our lives, let
Yeah,
alone medicine
yeah.
in general. So, just think about even now, you have a radiologist who has 100 studies to read through. How do they prioritize them? There's not a great way up front, but if you had some sort of AI or some kind of agent that, screened all of them for the worst possible things that could happen, a PE, a dissection, something like that, and then could reprioritize them for that radiologist, those are places where, the status quo, it's, six and one half dozen, nothing, nothing would change based on the status quo. But if they were to increase the priority of things that were, seen as a risk, that might save somebody's life because that might lead to, a more rapid read. Going back into ambient technologies, ambient scribes, not only could they scribe, but they could listen to what's happening. They could get a sense for what's going on with the patient. And they may also be able to suggest things that might save length of stay. For example, listen to the doctor talk about this patient, found out they had osteomyelitis, and then suggest that maybe they should get a PICC line sooner than later because they're going to need it to go out on 6 weeks of antibiotics in the future. I think there's all sorts of things on the margin where AI is going to help with a lot of things. One is obviously length of stay. Another could be clinical outcomes and help with triage decisions. We have some of this already with risk stratification, risk calculators. They're good on large scales, maybe not great on small scales, but as, improvements happen in technology, these could also help with triage. I think that the sky's the limit. I'm going off in many tangents here because I've thought about this quite a lot. But there, you could leverage these agents in many places, and it really depends on what problem you have. I mean, the purpose of them is to solve a problem. Back to the agent you were talking about discussing. Imagine you had, somebody was sitting in the primary care office, and they kind of gave an agent their spiel right off the bat, or in the ER. Maybe that's a new way of doing immediate triage where they describe what's happening, and then that sort of shuffles the deck in terms of patients coming through the ER initially. I mean, the sky's the limit. It's really limitless. possibilities, I think.
Yeah, it's exciting time to be a nurse. Um, Leslie, what are you excited about for the future?
So I think AI is great and it is going to be playing a part. I tend to stay a little bit more risk adverse because I want to see how those models are being trained, but not just how those models are being trained, but for a safety net system, are they taking into account that my patient is not English speaking? There's a visual or hearing impairment, the health literacy, the digital literacy, the comfort that a patient is expressing during that experience. Like if they're talking to an agent or there is some sort of AI that is involved, like how is that making our patient feel?
Mm-hmm.
Um, and then are there any cultural expectations that these models need to be trained on
Mm-hmm.
based on what their function is? So
Mm-hmm.
think I think we've got good bones to work with in that space, but it needs more training, needs more education. It needs more real life experience. I just came from an event last week where they talked about training the AI on human intuition, and I thought, how do you how do you train a machine to have human intuition? You can train it to be empathetic, but how can you?
Mm-hmm.
There were certain qualities that I was still like, I'm I'm gonna need to see that one play out before I put some
Yeah.
eggs in that basket.
Yeah, I think what we were talking about too last week is you're kind of excited to be more centralized and kind of set up a virtual. Yeah.
Yeah. So I think that's another problem we're trying to solve for is we're fairly fragmented in certain
Yeah.
areas. And so this program's doing this and this program's doing that, but there's no central oversight that takes those fragmented programs and moves patients between them and communicates. So I think that is definitely one thing that we are working on is how do we have that um, digital infrastructure that's more like a command center where
Yeah.
we're not just talking about patient flow, we're talking about all of these other aspects as pieces of care. And while they may sit next to each other physically, they would have very different oversight. So we're excited
Mm-hmm.
about exploring those opportunities.
Mm-hmm. Mo, where are you excited about seeing this go next?
Well, I mean, I'm gonna have to put my hospital medicine hat on, and nothing really better than throughput in my world. I know Stephanie can obviously relate. I mean, Mario said something that we actually were just discussing in one of the meetings. The amount of CAT scans and MRIs and you name it that are put in on a daily basis for, busy hospitals like the ones, we provide services for is just countless. And they're all stat, the whole like priority of routine and stat. And today everyone wants everything to be done as soon as possible, obviously. To be able to see AI get into the radiology world and does that stratification of giving some sort of where do I start from? I have a pile of the X number, I don't want to quote a number, of cases I have to read, and some of which could really be an emergency. Really would be a great way to see how this would obviously be quality care because we want to know the emergencies sooner than later. But then also help with throughput because then it can help stratify. And I think with that, the unintended consequence that it could do is something I tell my team all the time. Please avoid the unnecessary consults, avoid unnecessary testing, try and save resources to what is needed. But you keep saying this, and sometimes when the system helps you do that by, let's say, if every time my studies are always pushed to the bottom, and let's say as a medical director or so forth, I realize that Dr. X or so forth are always the ones that your studies are never a priority based on the stratification of the criteria. Maybe we need to sit and have a one-to-one and see what's your comfort level in handling certain cases or so forth. And it'll be an unintended consequence. That is a win-win, not to be punitive or to make anyone feel bad about their doing, but just as an opportunity to utilize resources and use it appropriately. So I do believe while we are thinking about it from a throughput and metrics and improvement perspective, that it actually does have a component to improve the human portion as well. One thing I really also, and I will, end on that so I don't take a lot of more time, is I really do believe in the concept that the physician patient communication, with the time they spend together face to face, has been affected by the amount of documentation and entering orders and clicks you have to do and so forth. That if I can have a modality like technology, like telemedicine and what we're discussing, that allows all this to be in the background, basically taking my notes and allowing me to have my assessment and plan generated based on how you format and analyze things and so forth. Just give me more time to speak with the patient, sit down, talk to them, just go back to basics and be able to actually do what we went to medical school or nursing school or nurse practitioner school or PA or all the clinicians, and be able to really just give that one-to-one between the patients and the physicians and their families, and let that stuff be more in the background and still provided with the technology and with the use of technology. I believe that this really would be something I'm very excited to see and get that value for the patients the way they deserve and the service excellence I look to provide.
We just got more emojis than ever. It's beautifully said. And obviously you're resonating. Stephanie, you and I were talking about this last week about like kind of the even kind of going back to this definition of a smart hospital. And you and I were talking about ambient. And I think when you say ambient, people think ambient scribing, and that's only one thing. I was talking to a nurse this morning, and I talked about that we're doing a study on computer vision AI, and she said, "What's that?" So yeah, just on the line of what's coming next, what's exciting. Do you want to kind of help define all the different types of ambient?
Yeah, well, I mean, ambient really does just sort of mean in the background, right? And
Yeah.
so, um,
Mhm.
it's certainly the place where we've seen the most traction initially is with ambient voice. But computer vision, really, thinking about the kinds of information we want to understand and ways to capture that with sensor-based technology so that we don't have to put it on the backs of the clinicians to click
Mhm.
boxes. I think is really exciting and where we're going to see the smart hospital take off. I come back to the comment that you made earlier about the CNO who said the smart hospital is the investment we have to make, but we have to survive today. The opportunities for virtual care to support throughput and patient experience are sort of the foundation of what justify and get us through today and the investment that needs to be made. But the infrastructure that puts in place allows us to think about what could be next. And I remember when I was talking to my own health system board about this kind of technology 5 years ago, my comment was, by using things like cameras, speakers, microphones, ultra wideband technology for sensing where things are in place, it's like having a process improvement engineer in every room 24 hours a day. We'll be able to capture information that's never been accessible before to help us really understand what underlies the problems that we're trying to solve. And there are things on the horizon that are going to add to that. Computer vision to uh, measure personal metrics, right? There's
Mhm.
ambient voice right now to understand patients, mood, psychology, cognitive abilities. There's computer vision things that on the, in the near horizon that are going to do things like measure vital signs and other biological markers in ways that then again reduce the friction for clinicians, reduce the variability in how those things are captured, and allow for us to really understand a whole new layer of information to analyze.
Yeah, and one other thing on there, Leslie, your daughter's a nurse, and I'm sure you're thinking about like the violence that nurses experience. So, and that's another ambient use
Yep.
is detecting escalating aggressive patients and like kind of rescuing earlier. So
Absolutely.
this is just all of you. This has been just a fantastic webinar today. And I think my kind of takeaway is that the smart hospital isn't defined by one application or one device. It's defined on how the technology in the room works together and in a single platform, so that every time one of those innovates, the room gets smarter. And the result becomes that the room becomes a kind of an active participant in patients' care. And we can have safer care, giving caregiver support and health systems the intelligence that they need, what you were just talking about, Stephanie. So thank you all. I want to end a couple minutes before the top of the hour so people can grab coffee before they have to jump into their next meeting. But there were a few questions that we'll try to get by email. So thank you all for joining us, and thank you, panelists. It was just a great conversation.
Thank you so
All
much.
those
Thanks,
emojis.
everybody.
Thank you all.
All
Great to
right, thanks.
talk with you.